As you can tell, I'm not Dr. Roman. He's out of town, and he sends his apologies for not being here. It is actually a great pleasure to be able to introduce this lecture. Primarily, I'm really excited about our speaker, but also to honor Dr. Charles Smith. This is his lectureship. I believe it's the 17th annual. Is that correct, Dr. Smith?
27th.
Oh, 27th. Sorry, I got the wrong one. 27th annual lectureship. And this lectureship was endowed by Dr. Letitia Kimsey, who was a former teacher and had followed with great interest Dr. Smith's medical course. Actually, Dr. Smith had served as her husband's physician, and when he passed away, Dr. Kinsey decided that she wanted to honor Dr. Smith with having a lectureship named after him. So we are very, very excited that this has continued for so many years. Dr. Kimsey's husband was, as I mentioned, a patient of Dr. Smith's, and their relationship was very close. And they really derived pleasure. They both shared a passion for teaching. For those of you that have known Dr. Smith for a long time, he has been known to be an outstanding teacher in our community and is one of the premier internists in our community. He served as the governor for the Kentucky chapter of the American College of Physicians and is very dedicated to the goals of the ACP. This, as I mentioned, it was the lectureship was established in honor of Armour Hugh Platt Taylor, who was Dr. Kinsey's husband, and James W. Smith, Charlie Smith's brother, was actually presented the first Charles Smith lectureship on March 16, 1987. So as you notice, this is a very long-standing lectureship. So we are very, very pleased to have Dr. Smith join us today. We had a wonderful meal last night, and for those of you who might have the opportunity of talking with him, he's a wealth of knowledge. You will can tell you how enjoyable it was to hear some of the stories and the people that he has known along the way. So I hope you have the opportunity of chatting with him. Excuse me, my allergies. It's beautiful outside. Finally, we have spring, but my allergies are really killing me. It is my pleasure to introduce our speaker today who will present the Charles Smith Lecture. Dr. Dan Matlock completed his undergraduate degree at Colorado School of Mines and stayed in Colorado to obtain his MD at the University of Colorado at Denver. And who wouldn't want to be in Denver? What a lovely place. He also obtained an M.P.H. following his fellowship in geriatrics and general internal medicine. Following completion of his degrees, he joined the faculty at the University of Colorado, where he's currently attending on the internal medicine and palliative medicine services and is the medical director of the Denver Hospice. Dr. Matlock has an interest in shared decision-making and advanced care planning for patients with an emphasis on heart failure care in the elderly. And obviously, we have a very robust heart failure program here at U of L, so this is very pertinent. He has been the principal investigator on several nationally funded research projects and has multiple publications to his credit. He's been a reviewer for 15 scientific journals, including Circulation, American Heart Journal, and JAMA. He currently holds a career award from the NIH and is very active in research. Dr. Matlock has been recognized by residents and students as a superb teacher. He's actively engaged in his community with an emphasis on the care of the underserved and is a member of the Colorado Coalition of the Medically Underserved, as well as one of my favorite groups, Physicians for a National Health Plan. In this era of emphasis on quality of care and life, as well as reducing costs of care, the topic he will share with us this morning is quite timely. I'm very pleased to introduce Dr. Dan Matlock, who will be presenting Improving Decision Quality for Implantable Defibrillators and Beyond. Dr. Matlock.
Thank you. Thank you for that nice introduction. Can everybody in the back hear me all right? All right, great. Well, I echo what a wonderful dinner we had last night with Dr. Smith. The stories were amazing, from the protocol for treating tetanus to leeches to thinking about life before CPR. It was just fascinating. So thank you for that. It was wonderful. I'm going to talk about improving medical decision quality, focusing on some of the work I've done with implantable defibrillators. And I'll get into that. I'm obligated to let you know I have no conflicts of interest to disclose. Whether that's good or not, I don't know. I acknowledge some of my funding from the NIH, the Patient-Centered Outcomes Research Institute, and the John A. Hartford Foundation and the American Federation for Aging Research. So before I get into my talk, I want you to think about this statement. There is a 30% chance of rain tomorrow. Now think about how you might explain this to an 8-year-old or 10-year-old. And when I lecture to the med students, I give a talk on statistics and risk communication. And I used to have the med students raise their hand and try to explain it. And I stopped doing that because it got too embarrassing. So Gerd Gigerenzer, who's a psychologist who does research in statistical literacy and medical decision making, actually asked people this. He asked 750 people on the street, what does it mean if there's a 30% chance of rain tomorrow? And he gave them 3 options. It will rain tomorrow in 30% of the region. It will rain tomorrow for 30% of the time. It will rain on 30% of the days like tomorrow. Most common answer, it will rain tomorrow for 30% of the time. And even more interesting were some of the comments. 3 out of 10 meteorologists believe it will rain. 30% means that if you look up to the sky and see 100 clouds and 30 of them are black, it's not about time, it indicates the amount of rain that will fall. And then my favorite, because I think it's correct, if we had 100 lives, it would rain in 30 of these tomorrow. And that last one, because I think it's correct, it highlights how hard it is to think about the future and to think probabilistically and to think in terms of uncertainty. And as we talk about medical decision making, this is very appropriate to think about. So just an overview of my talk. I'm going to talk about what I think one of the problems is in poor decision quality. And I'll talk about what decision quality is and what the aspects are of that. And then I'll talk about what the consequence of that is. And I think one of the big consequences is an erosion of trust in healthcare. Then I'll talk about what I think one solution is. I say the solution here, but that's probably a little overstated. One solution is if we can just do better shared decision making with our patients. And I'll define what that is, and I'll talk about some of the work I'm doing in that area. And then I'll talk about the challenges with shared decision making, and that we're all human and we have these funny little things that our brain can do to ourselves to make us not understand things or make decisions that may not be consistent with what we want. So first, the problem, poor decision quality. Before we get into decision quality, just broadly, what is quality? The Institute of Medicine defined quality with these 6 pillars. Quality care is safe, effective, equitable, efficient, timely, and patient-centered. And the way they define patient-centered is providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. So it's all about what patients prefer, patients' values. That's patient-centered care. Moving on to this concept, I introduced decision quality. Decision quality is defined as the extent to which a decision reflects the considered preferences of a well-informed patient and is implemented. So in other words, well-informed, so they're knowledgeable, and considered preferences, meaning that whatever that decision is consistent with that person's goals and values. So let me talk a little bit about, show some data on how we're doing with decision quality. So let's first start with that first piece, knowledge. So this is a really stark example of statistical presentations leading to poor knowledge. So in 1995, the United Kingdom Committee on Safety of Medicines issues this warning. Oral contraception pills increase the risk of potentially life-threatening blood clots by 100%. And if you look at that, that was 1995. This graph here on the y-axis is number of abortions in England. And I don't want to make any debate about abortion, but I think we can all agree it's a measure of unintended or unwanted pregnancies on some level. And you see the number was declining. And then after this pill scare, the number shot up. Likewise, the number of births increased in 1996. So that actual increase in the risk was 1 in 7,000 to 2 in 7,000, which is indeed a 100% increase in relative risk. That's a 100% relative increase, but it's a 0.14% absolute increase. And as I said, the 1996 abortions went up, births went up, and the ironic thing is the risk of blood clots with pregnancy and abortions is about tenfold that of oral contraceptive pills. So this is just that's a similar example of this relative risk versus absolute risk a little more clearly. So imagine a therapy where you have that's universally fatal. And we get some therapy that will lower that from 100 out of 100 to 50 out of 100. And trying to think of an example of this might be nitrogen mustard in the 50s and 60s for leukemia, where we had something that was universally fatal, and we come in with this therapy that can then cure this disease. That's a 50% relative risk reduction. And it is also a 50% absolute risk reduction. Now fast forward to most of what we do in clinic every day, where we're treating blood pressure, treating cholesterol, where we're dealing with much smaller numbers. I might lower mortality with a blood pressure medicine from 2 out of 100 to 1 out of 100. And that's a 50% relative risk reduction, but it's a 1% absolute risk reduction. And I think when you see it like this way, it's sort of easy to see, it's obvious, but even myself, and I lecture on this, when I don't have this slide in front of me, and I'm listening to the news, and they're throwing statistics at me, my mind will do these cartwheels. And I may interpret it incorrectly. And that's a common human problem. And it's even been termed in some of the psychology literature, denominator neglect, is when we hear a percentage, we just automatically put 100 on the bottom. A 20% reduction, it must mean 20 out of 100. But it could mean 20% reduction from anything. But as people, we don't think of it like that. We misinterpret. There's lots of data that doctors do this too. We're all human on this. And then even more concerning is this framing issue. And there's been some interesting articles about this. If you look in the major journals, the benefits are presented with relative risks. A 20% reduction in cardiovascular mortality. And the risks are presented in absolute risks, but a 1% increase in bleeding. And that's comparing apples and oranges. And journals are getting better with this. Journals are starting, like the New England Journal now demands you present an absolute risk in the abstract, but 10 years ago it wasn't that way. So if you look at old articles, you're going to get this mismatched framing. So let me transition to some of the work that I do. I do research with implantable defibrillators. This is the major primary prevention trial for implantable defibrillators. This is the SCUD-HEF trial. This is people with heart failure, class 2 or 3 heart failure, an ejection fraction less than 35%. Didn't matter if they were ischemic or non-ischemic. And they enrolled them and they randomized them to amiodarone, placebo, or a defibrillator. You can basically ignore the amiodarone. At the time they started the trial in the 90s, there was this question of whether an antiarrhythmic could be just as good as a defibrillator, and clearly an antiarrhythmic wasn't as good as a defibrillator. But the defibrillator, over 5 years, you see this pretty large reduction in mortality with the defibrillator. This number here is 36% 5-year mortality without a defibrillator versus about a 29% 5-year mortality with a defibrillator. That's a 20% relative risk, a 7% absolute risk reduction. And this is pretty good. As far as preventive medicine goes, this is about as good as anything we have. This is a big absolute risk reduction, I would argue. But talking about the statistics and the way we present that and the way patients understand that is interesting to look at. So I know this is hard to read, but this showed up in my mailbox, so I wanted to put it on a slide. This came from one of our groups in town, and they wanted me to refer more patients for defibrillators. And so they said, here's the recent landmark device trials. And these are companion trial, made it to SCUD-HEF definite. And this is, you open it up and you get the SCUD-HEF trial in here. And the key finding is a 23% reduction in the risk of all-cause mortality in ICDs compared to conventional drug therapy plus placebo. And I don't even know where they got the 23%. I don't think they went out to 5 years. I think they looked at an earlier time. But this is the way we present the statistics from that trial. And then if you ask patients, so I surveyed every implantable defibrillator patient at Kaiser, Colorado. We surveyed 400 people. We got about 300 responses. And we asked them, if 100 people like you got an ICD, how many lives would be saved over the next 5 years? Well, I just told you the correct answer is 7. But you asked people, and 40% said 53 out of 100 would have their life saved by the ICD. Another 20% said 28 out of 100, and about 15% got the correct answer of 7. And this is not unique. They show this over and over, where patients overestimate the benefits of therapy. And you can do the flip. Patients also often underestimate the risks of therapy. Although there's some nuances there. When you say something like the risk is 1 in a million, people overestimate the risk of something. It's hard to get less than 1 in 100 in people's minds. So you have to be careful with rare risks because people can overestimate those. But as far as benefits go, this is a big overestimation. I mean, this is a 400% overestimation. And you hear what I did there? I said 400%. I made it a relative risk to make it sound more important. So that's the knowledge piece, that we may not be doing the best job giving our patients the knowledge about the therapies we provide. But then that other domain of decision quality of values. And I could argue that this might even be the more important domain, making sure that the care we provide is concordant with what people want and patients' values. And I don't think we do a good job predicting people's values. So this is a study where they asked people, this is Karen Sapuka, she does a lot of work with decision quality, really interesting stuff. And she asked people about breast cancer decisions, what their top 3 goals and concerns were. And providers' predictions of what patients would say. 71% of providers thought keeping your breast would be one of the top 3 concerns. Living as long as possible would be one of the top 3 concerns. Looking natural without clothes would be one of the top 3 concerns. And nobody thought avoiding using a prosthesis was important. Then you ask patients, only 7% listed keeping their breasts as one of their top 3 concerns. Only 59% said living as long as possible was one of their top 3 concerns. 33% said looking natural without clothes was important. And another third said avoiding prosthesis is one of their top 3 concerns. So, and this is also not unique. You see this over and over when they've shown this with prostate cancer treatment, where doctors think one thing is important to men and men say other things are important. You see this in lots of areas. Now, I'll say I did this with defibrillators, and doctors and patients actually agreed that this value of living as long as possible and not living with progressive illness was the most important thing, and doctors and patients understood what was important for each other. So in a sense, ICDs are unique in that way, and that we all agree what are the most important values around that decision making. And another area that's really concerning to think about where we don't do a great job, this gets into some of the palliative care work, where we don't do a great job making sure care is concordant with what people are hoping for is where people die. If you ask people where do they want to die, 90% or more say they hope to die at home. And a few say that they hope to die in the hospital. They don't want to die at home for whatever reason. They don't want their family to have to remember that, or they have small children. And nobody ever says they want to die in a nursing home. And you look at where people do die, and 50% die in the hospital, 30% die in nursing homes, and only about 20% die at home. So this is another area where we're not doing a great job making sure that the care we provide is matching people's goals, which is, again, an element of decision quality. So just to wrap up this concept of decision quality, I've worked on some of the metrics around this, trying to develop a measure for ICDs. There's people working with the National Quality Forum to get decision quality measures to be used as a quality measure. There's some measurement problems. It's a hard thing to measure, and that's been probably the major holdup. But at least philosophically, as we think about the care we provide to a patient, we can think about, is my patient understanding what they're getting? Is what I'm recommending concordant with what they really want out of the rest of their life? So a good decision, if you have high knowledge and the care is concordant with their values, that'd be a good decision. If you have a patient who has no idea what they're getting, and they get something that is discordant from their values, I could argue that's a bad decision. And then I put these question marks here because there's probably good and bad decisions in each of these windows. You could have high knowledge and low value concordance, and maybe you're just not measuring the values correctly. Maybe somebody says, oh, I don't want a defibrillator, but my daughter wants me to have it, so I'm going to get one anyway. And who's to say there's anything wrong with that? I watch cartoons with my daughters, and I don't enjoy it, but I still do it because it's a wonderful thing to do. And then likewise down here, the value, you could have care that is concordant with what people want, and they may have no idea what you're talking about. And this might be the situation as people get sicker, cognitive impairment. Sometimes it's hard to make sure they understand everything, but you can still provide care that is concordant with their values. So I'm not sure if you would say that's a good decision or bad decision. But this is this concept of decision quality. And I make the argument we may not be doing the best job we can with it. And so then what is the consequence of that? Well, I think one of the first things to think about is why aren't we doing a good job with that? And so this is a survey of doctors. For you personally, what is the number one barrier to engaging patients in a shared decision-making process? And this is highly predictable. The number one barrier, not enough time for detailed discussions. I feel this when I'm in my primary care clinic and I've got 11 patients and I'm 30 minutes behind. My discussions around mammography shared decision-making or PSA shared decision-making don't get nearly as good as they should. And I do research in this area, so I feel a lot of guilt about that. But if I'm being really honest, it's hard. It's really hard to do a good job with this. Other things the doctors thought patients have difficulty understanding. There's no trusted source of information. And then a small number of doctors said, I prefer patients rely only on my recommendations. That's actually good that that's a low number, because I don't think that's right at all. So we're not spending the time to improve this decision quality. Well, what's the consequence of that? Well, patients, we don't have time, so patients are scared to question us. This is an episode of Seinfeld where Elaine, the doctor walks out of the room, and Elaine peeks at her chart and sees that she's a difficult patient. And the doc comes back in, and she confronts the doctor, and the doctor says, oh, that must be a mistake, and he erases it. And she says, it was written in pen. You just fake erased that. But this is a big fear, and there was this study done by this guy, Dominic Frosch, where he asked patients, why don't you question your doctors? And one of the biggest fears is they don't want to be labeled a difficult patient. This is a quote from that study. Is the guy going to be pissed at me for not doing what he wanted? Will he do what I want but resent it and therefore not be quite as good or in some way detrimental to my quality of care? So we're not doing a great job informing patients. We may not be providing the care that is concordant with their values. We don't really have time to do these discussions. And then patients are scared to ask us. Like, this is just not so great. And then you get this erosion of trust where you hear these things in the news. ProPublica published this Dollars for Docs and how much money doctors are getting from pharmaceutical companies. And then just, I guess it was last week or 2 weeks ago, the Wall Street Journal published this article where you can type in my name and see how much I've billed Medicare. And while there's problems with that data, there's ophthalmologists that bill for expensive eye medicines and it looks like they're billing millions of dollars when maybe they're not. It doesn't matter, because this is what the public's seeing and this is what the public's thinking. And you read what the public writes about this and they're not happy with what they've read. And you take the experiences they have when they see us in clinic and we rush them and we don't answer their questions. And then they see this on the news and it's no wonder we're getting this erosion of trust in medicine. This is really interesting. So I do research in shared decision-making and patient empowerment, and the BMJ publishes this special issue with all of this work on patient empowerment. And I initially loved this cover. Then I went to this conference, this International Shared Decision-Making Conference, and there was a doctor who's worked in human rights issues in Peru for his whole career. And he puts this slide up, and he talks about how much he hates this. And he really made me think, and I now agree with him. At first I thought, oh, wow, that's great. But every study, if you ask patients what they want from their health care, no patient wants to revolt against us. Like, nobody wants to feel that they need to revolt against the healthcare system. And it's terrible that this is where things are going. That patients need to revolt against their doctors. Patients want a trusting relationship with their doctors. Doctors want to have a trusting relationship with their patients. Nobody wants this. So while I initially liked this, I now kind of see it as something sort of gross. And if you look at this iconography, I mean, think about the amount of suffering associated with this kind of iconography in the last century. It's just not right that this is the kind of thing that's out there, I don't think. So that's the consequence, this erosion of trust. So I'll say, I should really change this to one solution is better shared decision making. There's lots of solutions. We need better policy. We need more time in clinic. We need to reimburse for time. But short of that, we also need to be better at what we're doing on a day-to-day basis. So I'll argue one solution is better shared decision making. So let me talk about what that is. This is not shared decision making. Which therapy would you prefer? Putting options, throwing risks and benefits, and leaving a patient to make a decision. There's nothing shared about this. Just throwing options at a patient. And we think, when we're well-meaning, we think this is what shared decision-making is. Well, it's your decision. It's your decision. You need to make this decision. And there's nothing shared about just telling them it's their decision. So there's lots of definitions of shared decision-making. By far, my favorite is one of the first ones, was this definition written in a book in 1985 and they called shared decision-making a meeting between two experts. And you could take out the two. You could say meeting between experts and include extended medical staff involved in this shared decision. But I love this definition because it highlights that there's two experts coming together. There's an expert in the medical science, and there's an expert in themselves and what's important to them and their values. And to really get to a shared decision, you need to bring those things together. That's why they're coming to you, because you're an expert in the science. But you, as a doctor and as a fellow human, an equal human, need to respect where they're coming from. If you go too far the other way, you get paternalism. We all are familiar with what that is. That's the 4% of doctors that just prefer the patients rely on my recommendations. And arguably that is an easier day if patients will just do what I say. And then the flip side, though, is what I was talking about. This just throwing options at patients and telling them it's their decision. This consumerism. You're a consumer. You choose from the smorgasbord of healthcare that you have no idea what's even out there. That's not right. And one of my favorite articles written by Tim Quill called that patient abandonment. So this is what shared decision making is. I think it's a mix of the two. So let me get back to implantable defibrillators. And this is a patient. This is not my patient. This is a free image off Google Images that reminded me of my patient because I didn't take a picture of my patient. But there was this patient when I was a resident, and I was a resident in the early 2000s when implantable defibrillators were really just starting to catch on. And he was a farmer in the San Luis Valley in Colorado, which is this beautiful sagebrush valley in Colorado just south of South Park. It's just a gorgeous part of our state, but it's also pretty poor. And he came in, he was 77, and he had kidney failure, and he was being admitted for kidney failure and heart failure. And I admitted him, and he didn't want a lot of things done. His family told me he had to come in. And then I go round on him the next morning, and he's gone. And I ask, where is he? And he's down in the EP lab getting an ICD. And this was one of the private hospitals in town where the residents don't have as much control. I don't know if you have that here. And we just kind of watch medicine happen and learn, and rather than when we're at the county hospital where we kind of run everything. So this was at one of those hospitals where we didn't really run everything. And I went and talked to him afterwards, and he had no idea what had just happened to him. He had no clue. And now he has this resuscitation device inside his body. This gentleman that I just talked to who told me, I don't want a lot of things done. And I could argue now that I know more about defibrillators, I knew very little about them at the time, except that they were. With his kidney failure, he should have been a lot more stable before he gets a primary prevention defibrillator. But it frustrated me a lot, and it made me really, really start developing this hypothesis that we're not doing a good job making sure that people understand what they're getting when they get these things. And that experience as a resident is partly what drove me to do a research fellowship and really start getting into studying shared decision making and can we do better. So I showed you the benefits of ICDs, and I argue they are wildly beneficial. But they also come with a host of harms. So there's the procedural risks. And with ICDs, this is actually pretty small. These are minor. It's arguably a minor procedure. But there's some other risks. So there's one study following the MADE-IT2 population, basically the scud heft, of a similar trial to scud heft, but only with ischemic cardiomyopathy. And they showed that people with ICDs had more heart failure admissions they said, well, likely what's happening is you took somebody who was going to die of sudden death and kept them alive, so you're keeping a sicker cohort alive. So they're having this progressive heart failure now. There's lots of stuff written about anxiety and depression and post-traumatic stress disorder and quality of life. I have a half-day clinic in the heart failure clinic, and I get referred patients with ICDs who are having often some emotional issues. And I have one patient who every night he'd wake up thinking he got shocked by his ICD, and he'd call and they'd interrogate it, and nothing had happened. It was his nightmare from his memory of getting shocked. It was just classic PTSD with recurrent nightmares. There's also concerns about inappropriate shocks. This is something that is getting a lot better as the technology goes down, but the early ICDs could shock people who are just having a sinus tachycardia because they didn't do a great job distinguishing ventricular versus atrial rhythms. They are getting a lot better in this area, I'd argue. Then there's concerns about device malfunction. A couple of the major companies have had big recalls of leads. And then finally, the potential suffering at the end of life. One of my mentors, a cardiologist, Fred Masudi, when he talks on ICDs, he says ICDs are interesting because the benefit is also one of the big risks. So getting shocked is the benefit, and getting shocked can also be the harm. And it really all depends on where you are and your context in life. There was a study that Nate Goldstein did. He does a lot of work on this deactivation decision at the end of life. And he surveyed all the hospices in the country and asked how many had a patient get shocked by an ICD. And half the hospices in the country in the year prior to the survey had a patient get shocked by an ICD. And I argue that medicine doesn't get much worse than that. When a person's in hospice dying of some other cause, and the family's standing vigil, and then the patient starts getting shocked by an ICD that the poor hospice nurse didn't even know was there, didn't think to turn off, and the family didn't really know what was there, and the patient didn't really know what it was all about, and then they get shocked by their ICD at the end of their life. That's bad medicine. So there's risks and benefits, but I argue I do shared decision making, and shared decision making is most appropriate when there's a decision that really requires a trade-off. And I think this is the big trade-off with ICDs. And I alluded to it with that trial talking about more heart failure admissions. So this is a model that was published in JAMA. These are patterns of functional decline. And you have people who are healthy, and they get heart failure. And then they go through this series of exacerbations. And this can go on and on for some unpredictable amount of time with heart failure. Prognosis is incredibly difficult. And they'll be following this path, and then eventually they will die. You could also be doing this path where you get heart failure, and while you're still early in your heart failure, you could die suddenly. And ICDs only treat this. So you're making this trade-off. And I always worry when I present this, I said this the other night, that I come across as anti-ICD. And that's not what it's about at all. I'm not anti-ICD at all. If I got class 2 heart failure for some reason, I have 3 young daughters, I would get an ICD. I would absolutely get one. But I can also see a time in my life where maybe my daughters are all grown, I'm short of breath going to the mailbox, and dying quickly may not be the worst thing that can go. When I did my geriatric fellowship, you hear this from patients. I don't want a lot of things done to me. You know, it's interesting if you ask people, do you want to prevent sudden death? Yes. Do you want to die in your sleep? Yes. And that's where I argue there's a decision there. There's something to talk about there. Because where we trade off those things, and I'm guilty, I would say yes to both of those things as well. I think most of us would. We'll live as long as possible, and I'd like to go very quickly at the end. So when you get an ICD, you've got this discussion to have. So I've surveyed a lot of docs about how they have these discussions with patients. So I asked physicians who has the discussion, and one of the cardiologists said, I have the EP doctors actually explain it to them in much more detail. And then an electrophysiologist says, and most of them have already made up their mind by the time they come to see me. And I'm guilty of this in primary care. There's something I don't know a lot about. I'll let the specialist talk to them, or I think the specialist is going to talk to them. And then the specialist is over there thinking, well, they referred them to me to have this procedure, so I better do this, or I'm going to hurt my referral base. I want to make sure the primary care doc is happy. And so you get this situation like this. There's nothing evil here, but it's not great for patients if nobody's having this discussion and nobody's owning this discussion. We also surveyed 1,200 cardiologists. We did this national survey through the American College of Cardiology. And we asked, to what extent does each of the following factors affect your recommendation regarding ICDs for primary prevention? And we had them rate these things on a 5-point Likert scale. We scored it 0 to 4. So 4 is the maximum. And you see things like mortality benefit data, guideline recommendations, 3.8, 3.6 out of 4. But you look, patients' preferences, 2.9 out of 4. Patients' knowledge about ICDs, 2.2 out of 4. And I argue there's a right answer here. If we're really doing shared decision making, you bring the knowledge, mortality benefit data, and guidelines should be 4 out of 4. And patients' preferences and patients' understanding should also be 4 out of 4. That's the meeting of experts. Bring these things together, and you've got good shared decision making. And this was a big theme in among the cardiologists. I think my biggest concern is if I convey the risks to them too strongly, that they will choose or make an unwise decision and not proceed with therapy. And this was a cardiologist who worked at he was a salaried cardiologist, worked at one of the capitated systems, no incentive to put in ICDs. And there's nothing evil about this. I say paternalism, but it's paternalism in the best, most well-meaning sense of the word. This is a feeling I have with my daughters, where I'll turn off something bad on the news so they sleep well at night. I don't want them to see this, because that's not good for them, because they're little. But I don't want that works when you're a father and your daughters. That doesn't work when you're adults. Two adults should not be thinking this way about each other. I don't want some doctor thinking this about my father. If my father goes to get an ICD, I want them to treat my father as an equal and not be scared to tell him the risks because he'll make an unwise decision. But it's an understandable thing. I just argue it's not right. So back to that survey we did of the patients with ICDs, we asked them, when should an ICD be turned off? And we gave them some choices, and 59% said the ICD should never be turned off. So the majority of patients with ICDs don't even know that you can turn it off. So if you have this thing in your body, it starts shocking you, and you don't even know you can turn it off, no wonder people are getting anxious and post-traumatic stress disorder, because they feel stuck with this thing. When in fact, they have a lot of control. We also asked about their decision process, and 36% said they weren't even asked if they wanted an ICD. 17% said they didn't want it. 16% said they were involved in the decision less than they wanted to be. So I think we could do better. So I say I'll get into some of the work we're doing, and I'll refer you to most of this. I'm not going to show a lot of it, but we have a PCORI pilot grant to develop decision aids around defibrillators, and we've developed. There's this question of decision aid. Do you need this long website, or is a one-page thing just as good? And so that's the grant we put in, said let's make a bunch of decision aids and compare them to each other. So we have a one-page pro-con FAQ list. We have a 4-page paper decision aid. We've made an 18-minute video, and then we have this interactive website. And we're just starting to pilot that. But to develop those, we've had 28 patient interviews and 3 focus groups of patients, and we have an ongoing patient advisory panel. It's gone through several clinician groups at Kaiser, Colorado, University of Colorado, Denver Health, the VA, and then a national group of clinical and decision science experts as well. John Mandrola was one of our experts. He's an electrophysiologist here in town who's a good friend of mine. And it gave us lots of comments. We got 24 pages of comments from this expert panel, and a lot of these comments conflicted with each other. But we tried to incorporate all these things, trying to make something that's good for patients, but also something that doctors are willing to use. So this is just a look at the front page of the paper one. The last slide, I have our website where you can go look at the video and the website if you're interested. Like I said, we're still in the process of studying these. And it's interesting, so far patients are liking the video the best because we're talking about these tough trade-offs, and they like to hear from other patients about this trade-off. They like to hear it from a person rather than read it on paper. But we're still learning about that. But just backing up and even what a decision aid is. So there are the International Patient Decision Aid Standards, and there's a whole bunch of things that are in this, but really there are 4 categories. You should provide information about the options. There's data that sometimes patients don't even know they were making a decision. The doctor thought they were having a discussion about a decision, and the patients don't even know they're making a decision. So it's good to say, we have a decision to make, and here are your options. That's a good thing to put on the table. Presenting the probabilities in an unbiased and understandable way, and I'll show you some of that. Providing methods for clarifying values. This is one of the things that makes a decision aid different from an information pamphlet, is you want that person to turn inward and explore their own values. And structured guidance for deliberation and communication. This is that empowerment piece. Don't be scared of your doctor. Write down your questions. It's okay to ask your doctor questions and just empower them to have that discussion. You don't need to be scared of your doctor. If they label you a difficult patient, that's okay. This is a big deal that you're trying to think about. So in other words, a decision aid is an accurate, readable, and balanced tool that helps with knowledge, helps with values, and helps with empowerment. All those domains of decision quality I talked about earlier. And do they help? Well, there's a Cochrane review of 115 trials of decision aids, and they improve knowledge, they improve value treatment concordance, and they improve lots of other measures of decision making. But most of these are sitting on shelves because we haven't done a great job also bringing doctors into this fray. A lot of people who work in decision aids focus only on the patient input and forget that doctors have a large perspective here. And that's been informative to me making the ICD decision aids. Doctors have strong opinions about how we present things. So again, this is that SCUD-HEF trial at 7% absolute risk reduction. And here it is presented another way. This is called a pictograph or an icon array. And there's lots of data that if you show people statistics presented like this, they're much more likely to answer knowledge questions correctly in the days to weeks after they have that discussion. And it's the same thing. You see the 7% absolute risk reduction, 36% die, 29% die. We have the 7 green faces. And this is a better way for people to understand complicated statistics. We also, in the risks, we present the risks. Another thing, you can do this in your clinic today. Instead of saying 4% experience bleeding, say 4 out of 100 patients. 2 out of 100 patients. If you put it in what's called natural frequencies, people are much more likely to understand that percentage. And that's something you can just stop using percentage when you talk to patients. Say 4 out of 100, 2 out of 100, 1 out of 100. And people will understand that better. You'll confuse them if you start changing the denominator. Well, 1 out of 25 or 1 out of 50 and 1 out of 100, that's a lot more confusing. But if you keep that common denominator and then compare the statistics, then you can help people understand things better. Now, it's interesting. We in these ICD decision aids, we originally had the pictograph for these, and the docs hated it because you had 7 green faces for the benefit and 7 red faces for the risks. And they're like, well, this looks like a wash, and ICDs are clearly not a wash. This is life-saving therapy versus bleeding. Some of that 4 out of 100 bleeding is actually pretty minor. So that's why we're presenting the risks this way in the tools we've developed. We're trying to make, we're starting our pilot trial now, and we're trying to get into this decision window. Primary care refers to a cardiologist. Cardiologist refers to an electrophysiologist for an ICD, and this is when the patient is in a window of making a decision. We're trying to make tools that get in people's hands before the discussion with the electrophysiologist, because that data I showed you earlier, that time is one of the biggest barriers. If we do anything that makes time longer, we'll have a big implementation problem. So we're working with the clinics that we're working with the nursing staff to mail tools or have patients come in early to watch a video. We're learning what patients like best from this trial. But we're trying to get into this decision window to make things better for patients and easier for docs. And then by the time that patient has a discussion with the doc, that discussion could be down the road. The patient already knows some of the basic stuff, and the doc can really dig into more what's important to that patient. So that's some of the work we're doing, and I'm happy to share that. We're also doing some work with destination therapy, left ventricular assist devices. It's also on that website at the end. But so I talk about and I preach shared decision making, but there's a lot of challenges. We're all human. And I want to talk about some of that because some of this is kind of fun. So this is a book published by Dan Kahneman called Thinking Fast and Slow. So Dan Kahneman and Amos Tversky won the Nobel Prize in Economics in 2002 for their work on decision psychology. They're not economists, but they did a lot of work in economics and the way people make decisions with money, and that's why they got the Nobel Prize. And this is this behavioral economics that you were hearing more and more about. This is a great book. I highly recommend it. It's pretty thick. It's an easy read. It's just thick to think about. You read a couple pages and your mind's running. So it's not a quick read, I would say, but it's a fun read. But they have some interesting things. So one of the challenges with decision making, if you put too many options in front of people, it gets harder. And this was a great study. This isn't in medicine, but this is a great study where this woman, Iyengar, in Colombia, did this study where she put 24 jars of jam out in the grocery store and watched people. And 60% of people stopped to look, and only about 3% bought jam. Then if they only put 6 jams out, 40% stopped to look, so it wasn't quite as interesting. But of those, 30% bought jam because it was easier, and people were more satisfied if options were limited. So you notice in our ICD tools, we're not talking about single lead versus dual lead. We're not talking about Boston Scientific versus Medtronic versus St. Jude. That's really not a decision for the patient. That's a decision the doc should make. We're trying to get into what are the big values that are important in a defibrillator decision. So you don't want to put everything in front of a person because you're just going to make things worse. And doctors are guilty of this too. So this is a great study where physicians were asked, there's a 67-year-old farmer with hip osteoarthritis. You've tried several NSAIDs, and you've stopped them because of either adverse effects or lack of efficacy. And you decide you're going to refer him to ortho for consideration of a hip replacement. And the patient agrees. But before you refer him, half of the people got the question on the left. There is one NSAID that the patient has not tried, ibuprofen. And the other half got this on the right. There are 2 NSAIDs the patient has not tried, ibuprofen and piroxicam. And then they were given choices. What do? Do you just refer and start the ibuprofen? Or do you refer and not start any medicine? And then over here, what do? Refer and start ibuprofen, refer and start piroxicam, or refer and do not start any medication. And when you give more options, we're more likely to not make a decision. It's just completely counterintuitive. So these are doctors making these decisions. So we're all susceptible to these cognitive biases, is what the decision psychologists call them. And the lesson here is when we can avoid it, we don't expend cognitive effort. We prefer to make a quick decision that we don't have to think about when we can, and that's our default. And it takes work to start weighing the pros and cons of things and make a decision. And that's one of these themes in that thinking fast and slow is we don't like to expend cognitive effort. Another thing is we're very susceptible to framing. This is another study. These were medical students, and this was done by Kahneman and Tversky, actually, in the early 80s, I believe. And they asked med students this. They said, imagine that the U.S. is preparing for the outbreak of an unusual Asian disease, which is expected to kill 600 people. 2 alternative programs to combat the disease have been proposed. Assume the exact scientific estimates of the consequence of the programs are as follows. And half the people got them presented this way, and half of them got it presented this way. And you'll see the difference. Here, program A, 200 people will be saved. Program A at the bottom, 400 people will die. Those are mathematically identical. And in program B, there's a 1/3 probability that 600 people will be saved, and a 2/3 probability that no people will be saved. And here they flip that and talk about what the proportion that will die. So these are mathematically identical, just different presentations. And what they've done is they do a gain frame, you're saving people, and a loss frame, you're losing people. And you look at when you present a gain frame, 72% of people take the more conservative option. When you present it as a loss frame, 78% of people chose the more risky option, or the gamble. And this is another common human behavior. This is partly what they won the Nobel Prize on, is when we're faced with gains, we're risk averse. When we're faced with losses, we're risk seeking. And that's something seen over and over, and it's partly why you think about, you go to Best Buy and you buy a new Blu-ray player, and they offer you $100, and they offer you $15 for another year of insurance. You're basically saying that there's a 15% chance this is going to fail in the next year, which is not true at all. And Best Buy makes more money on those little things from a profit margin perspective than anything else. Never buy those little insurances. Just insure the $100 yourself, because it's a much better decision. But you just gain something, so you're risk averse, so you're more likely to buy a little insurance. And on the flip side, you lose something. Oh, let's go double or nothing. I just lost, so let's double it. Double or nothing. Let's do this again. And that's a common human behavior. And these are doctors. We all do this. So the way we frame things is a big influence on the decisions people make. And so this is what we've done with our tools. We say 29 die, 71 live, 36 die, 64 live. And we've tried to present a balanced frame. So we're just presenting both to avoid a framing effect. So summarizing the psychology, I just have a few slides left. I think we'll be okay on time. Humans don't naturally think about probabilities. That's what I talked about in the beginning. Humans prefer to avoid cognitive effort. Humans are influenced by framing. And then the last thing I'll talk about is this concept of death as another thing that humans don't like to talk about, which is dying. And so we asked people around their defibrillator decision, do you discuss deactivation? And this is from a doc. It's an end-of-life conversation. When you're putting them in, you're not having an end-of-life conversation. You're having a prolongation of life conversation. And I understand this sentiment, but we don't like to talk about death. I told you we're getting into destination therapy LVADs. Here's an ad for DT LVADs. The end of the line with medical therapy doesn't mean an end-of-life discussion with your patients. Get a destination therapy LVAD. And I just think this is so wrong. I think DT LVADs are another amazing thing, and for some patients they are amazing. But when you get to the end of the line with medical therapy, that's the time you have a discussion about what are your goals? What are you hoping for the rest of your life? We have one of the most major and invasive things to offer you that may give you a lot of benefit. It doesn't mean you don't have the discussion. It means you do have the discussion. But we don't like to have the discussion. So this ad appeals to people. This is a decliner, a patient who declined an ICD. And he was a hospital chaplain. And he says, going into my decision is also the fact that I can't work because of my medical condition. I can't work at the hospital. I can't work at the church. My life is sitting here watching TV. To take a defibrillator would just lengthen the process I don't really want lengthened. And so he declined a defibrillator, and the doctors were mad at him. And he's in this interview, he was sad. I worked at this hospital, gave 10 years of my life there as a chaplain, and they got mad at me because I didn't do this thing they wanted. And he was really hurt by that when we talked to him. So I say a fourth thing is humans don't really like to talk about dying. We're starting to work with this social psychologist who does work in terror management theory. And his theory is that basically all of human behavior is somehow related to a fear of death. I'm not sure that's completely true, but it's kind of fun to talk to him and think about the experiments we can do with that. So in our tools, we're trying to talk about dying pretty directly. And we've stolen some language from the palliative care communication teaching, where we say you are facing a decision that might make some people feel uncomfortable, just acknowledging it, trying to normalize it. Although this may be hard to think about, other patients like you have wanted to know this information. And we've tested this language with patients, and patients are like this, and they're better able to come to this complicated trade-off of sudden death versus progressive heart failure when it's presented in this sort of way. We're also trying to frame it as both options are reasonable. Not one's a gain or a loss, but they're both reasonable, and we're using paraphrased quotes for that. So we show the picture, and about half the patients really like the picture, and the other half don't understand them, but they don't mind them, so we're keeping them. Because it's hard to come up with a standard tool that fits all patients. So we're doing our best. But they like this. I'm not ready to die. I have so much I'm trying to stay alive for. Even if it means getting shocked, I'm willing to do anything that can help me live longer. Versus, I've lived a good life. The idea of dying quickly sounds like a painless way to go. I've always said I hope to die in my sleep. Going through surgery and getting shocked is not the kind of thing that I want. Both of those statements are very reasonable things for a person to say. And both of those have very big implications for whether or not you should get an ICD. And I think this is partly why people like the video better, because you actually hear patients say this rather than just reading it, and it feels a little better. So just closing here, I talk about shared decision making, and I say I preach it, and I think I feel myself sounding like I'm preaching it. And I recognize there are a lot of challenges. But I wanted to point you to the new heart failure guidelines. And they haven't changed that much, but they've changed in one very important way. These are the AHA-ACC heart failure guidelines published last summer. And this is just the typical ICD Class 1 recommendation. If you meet these certain criteria of class 2 or 3 heart failure, ejection fraction less than 35%, 1 year meaningful survival of more than a year, you should get an ICD. But they added this asterisk here. And this is brand new, and I'm excited about this because it's one of the first times shared decision-making has infiltrated the guidelines this hard. And it says counseling should be specific to each individual patient and should include documentation of a discussion about the potential for sudden death and non-sudden death from heart failure and non-cardiac conditions. So that trade-off, there's a trade-off between sudden and non-sudden death, and it's in the guidelines that we're supposed to talk about it. Information should be provided about the efficacy, safety, and potential complications of an ICD and the potential for defibrillation to be inactivated if desired in the future. So deactivating an ICD and having a discussion about that is in the guidelines. This will facilitate shared decision-making between patients, families, and the medical care team about ICDs. And even there's a new proposed quality measure published by the ACC, AHA, AMA, the endorsed heart failure quality measures. And you look at most quality measures, and they say things like, if you have these criteria, you should have an ACE inhibitor. If you have these criteria, you should have a beta blocker. And it's a underuse measure. It's a rate of use. For ICDs, it came out with not rate of use, but rate of counseling. If you meet these criteria, you should be counseled about an ICD. And I'd agree with that. It's a wildly beneficial therapy. You should hear about it if you're eligible. But it doesn't mean that the rate of use should be the measure of quality. It should be the rate of discussions. And one of the people I work with was on the committee that wrote these, and he says that behind closed doors, there were near screaming matches about should this be an underuse measure or should it be written this way. And I'm glad it turned out as it did. So that's all I have. I can entertain any questions. Feel free to email me. I'm happy to have a discussion or a debate about anything. And I put our website down. I'm not selling anything. Corey requires that we don't make money off this. But I'd love to get these out there. If you have feedback, go take a look at our tools that we're working on. So thank you. With that, I'll answer some questions.
Identifying non-spiritual patients, and how usually this sort of thing only comes up, especially with seasonality and capacity, when someone actually does agree with something.
That's a good comment. So the question is, can I speak about how we do a poor job examining what people have decisional capacity? And I can't really speak. I don't know the data on that, but intuitive, we don't do a great job on that. And then the other part of that was the comment that it seems like those debates come up about does this patient have decision capacity only when they're going against what we recommend. And it's a great comment. That'd be actually an interesting study. I don't have data on that either, but that's a really interesting thing to think about. So I think I'll just agree with you.
Any other questions? I also really appreciate this talk. The decision you're talking about is that not specifically get what they're working on. And unfortunately, I think that most of the fields have right.
Right.
So how do you balance that, having, on one side, we presented data that said we want it easy and not require a burden as a physician and a patient. And then we have incredibly complex decisions. This is complex, but it's simple.
Yep.
Compared to the majority of other decisions that we're talking about. And so some guidance, how do you apply these to those? So I do weight management. So
right.
But some of this comes so directly that I had no idea how to do this situation because they really want me to tell them what to do because it's such a complex field for the business relative.
Right. So that's a good comment. So the question was, this is in some ways an easier decision to think about because it's dichotomous, and I agree completely. It's much easier to write papers and grants and make decision aids when there's just a yes or no. But most of what we do in healthcare is actually not that way. There's multiple options. The decisions happen over time. Decisions can change. And how do you do this work then? So I think I do work on decision aids, and I'm not sure decision aids work as well in some of those settings. But that doesn't mean you can't do shared decision making. So you can make, and I don't think making a recommendation is discordant from shared decision making. I think patients, that's that abandonment, just giving them options and telling them to choose is maybe not the best shared decision in these settings, but rather there's a bunch of things on the table. Tell me what's important to you. So you've got a little hypertension, there's some new weight loss drugs, or, there's some surgeries I could offer you. Tell me what kind of things you might be willing to do. So you can still do that. You can inform them, still get to that value concordant piece. It just might not be with a nice tool where people are checking a box yes or no. But I think you can still do you can still improve knowledge, and you can still do value concordance, even in these tough things. It comes back to our behavior. Now, the downside is that'll get you behind in clinic. But that's another discussion. I don't know if that's an answer to your question. And there are people doing weight management decision aids. You can email me, and I can send you some, see if you like them or not.
Well, I think that's a very thought-provoking discussion. It made me realize I'm probably not doing this as well as I can, and I hope to do better. And I'm sure Dr. Matlock will answer your questions. I did want to, in Dr. Roman's absence, present you with something.
Oh, wow.
Giving everyone, all of their outside speakers.
Oh, that's
they have to
cool.
fly home, which will be difficult with this, so we'll send it. But this is a Louisville Slugger bat that says Daniel Matlock, M.P.H, 2014 Charlie Smith Lecture, University of Louisville, April 17, 2014.
Wow, that's the coolest thing. That's really cool. Yeah, thank you. Oh, that's good. Thank you. Can I see it?
Yes, absolutely. We're going to get some pictures too.
Wow, look at that. This is way cool. Oh, I should turn this off.